It's my pleasure to introduce our team now and the patient. I have Dr. Lene Brink on my side and a good team and sociology team and Mette, our experienced nurse. The patient is a 75-year-old male with quite a number of comorbidities, diabetics, and also cardiopulmonary problems. He has been diagnosed with a submucosal lesion located in the second part of the duodenum on the top of the head of the pancreas. And the question is now what to do. The patient has been, the patient history has been evaluated on an MDT conference, and they decided that an EUS-guided biopsy should be taken in order to find the exact diagnosis. Because if resection is advisable, this is going to be a Whipple procedure, which is quite a big surgical procedure in a patient with lots of comorbidities. So this is, of course, an important question. If we can shift to the ultrasonic image, you can watch the lesion here, and we look at color Doppler, and it's actually also quite vascularized. Quite vascular. As you can see, there are some vessel signals inside. It might be a GIST tumor. It can be a neuroendocrine tumor. However, we don't know. If it is a GIST, we know that if there are lots of vessels, this is in favor of a pre-malignant GIST. So it is even more important now to get a diagnosis from it. So the endoscope is introduced in the duodenum, the second part of the duodenum, and we will now choose the needle. Whenever we are talking about GIST tumors or pancreatic tumors or a lot of other tumors, we will prefer an FNB and a crown cut FNB. I'm now using the Medi-Globe new TopGain needle for this, and Lene will perform the biopsy. It is shown that for GIST tumors, the method is quite in favor of third generation FNB crown cut needles, and therefore that's what we are going to be using. Now, first Lene will do the position of the sheath lengths in order to protect the endoscope. And I think maybe the patient is going to have a little more anesthesia. He's moving just quite a little. And now we will do slow pull, but now the puncture, the needle, is coming out, and Lene is using this, the stabbing method, because the tip is a little more blunt. We will use the slow pull method while doing a biopsy in and out of the lesion. As you can see here, quite well. The needle tip is very well visualized, and while doing this also in a taking from different parts of the lesion in a stabbing fashion in order to get cores out. Okay, we will remove the needle now and expel the material. While we are doing that, you might maybe measure the size of the lesion here. The lesion size is about 25 millimeter, as can be seen here. So, but we will expel the material. Oh, sorry. And 2 sec. The needle tip is going out. This material is, of course, histological material. So we will finally put this in formalin. That whenever it's difficult to expel, the stylet is good, and also this knowledge is often often a sign of a blocking core. So yes, we get very good material here. Very good material. Wait a minute. Yes, yes. I don't know whether that can be seen, but you can see cores inside here. But finally, we will put formalin in, and then the cores are better visualized. But I will go again to assist Lene for the biopsy. Usually 2 biopsies of such a lesion, maybe 3, depending on the material you get out. The sheet lengths, normally you can place the sheet lengths and then don't touch that anymore, but you have to tell the nurse that the sheet length is not to be adjusted. And now the needle comes out, and the stabbing and the slow pull. Hook, yeah. Yeah. In and out, that's a good. Yeah. So the fanning method is used in order to get material from different sites. Okay. I think that was perfect. And we will expel the material. Så er vi færdige, ja. So again, the needle tip coming out, and we will expel the material. See, again, it's in most cases you can expel it, but if there are big cores inside, then it may be blocked, and then the stylet is to prefer. Yeah. See lots of good material. Don't take it in. Okay. I think we're done. Yeah, I think I see good cores. Yes. So I think we finalized the case, and again I would like to thank all the good people in the room, and we are done. Thank you.